This is attorney Jay Vaughn with the law firm Hendy Johnson Vaughn Emery. We have offices in Louisville, Kentucky, and Fort Mitchell, Kentucky, right near Cincinnati, Ohio. I'm a plaintiff's trial lawyer, been practicing approximately 20 years, handling primarily truck crash cases and traumatic brain injuries. And today I'm just going to talk about common misconceptions about traumatic brain injuries. First, it's common for me to hear in these cases from either defense lawyers or defense doctors, well, your client didn't lose consciousness, then they can't have a traumatic brain injury. That's false. There's so much research and literature out there and published materials that say the opposite. One of the most known is Muriel Lezak, a book on neuropsychological assessment. I actually have it right here. This book talks about what you need for a traumatic brain injury, and loss of consciousness is not required. There is a textbook by Levin, Mild Head Injury, published in 1989. There is a paper by James Kelly, Dr. James Kelly, Diagnosis and Management of Concussion in Sports in Neurology, Journal of Medicine, in 1997. There are other guides, including the definition of mild traumatic brain injury by the American Congress of Rehabilitation Medicine I covered in the first video. So accompanying these videos is an article that I wrote that has a bunch of these resources. The second common misconception about brain injury: if you have a Glasgow Coma Scale, also known as GCS, of 15, you can't have a TBI. That's false. If you look at different articles, one of which by the Journal of Head Trauma Rehabilitation from May-June issue in 2018, it talks about individuals who have a GCS, a high GCS of 15, can still suffer a traumatic brain injury. Also, back to the Mild Head Injury textbook by Levin from 1989, also supports that you don't have to have a low GCS. You can have a score of 15 and still have a TBI. And then there's a really good article came out in the Journal of Neurology and Neurosurgery Psychiatry in 2004 called The Predictive Value of Glasgow Coma Scale After Brain Trauma, Change in Trend Over the Past 10 Years. And it talked about how Glasgow Coma Scale really is designed just for acute trauma. So first responders can communicate with emergency room staff. What type of patient am I getting? Someone who's conscious and with it, or someone who's in a coma? Do we need a neurosurgeon on site? That the Glasgow Coma Scale really doesn't have much predictive value of long-term outcome of brain injury. There's other things such as post-traumatic amnesia and other ways to determine the severity of a head injury long-term. That Glasgow Coma Scale really isn't designed for, again, long-term outcome of brain injury. Another common misconception is that, well, the emergency room doctor didn't diagnose a TBI. Therefore, you can't have one, your client can't have one, and that's false. There's been studies that came out. One, the accuracy of mild traumatic brain injury diagnosis from Arch Physical Medicine and Rehabilitation in 2018 that talked about how frequently brain injury isn't diagnosed in the ER and the reasons for that. And Concussion magazine in 2018 entitled A Comparison of Emergency Department Medical Records to Parental Self-Reporting of Traumatic Brain Injury Symptoms determined that brain injury is missed a lot in the ER. Again, not because the ER doctors don't know what a brain injury is. It's because their focus is on doing a triage of the patient. Is this someone who needs a brain surgery that could be dying, that has a brain bleed, or is this person going to be okay, at least in the acute phase? And I can focus my attention to someone who just came in, who's unconscious, who had a gunshot, someone who suffered a traumatic fracture and needs emergency surgery. And then finally, there's a really good discussion about the ER department and concussions that came out by the put out by the American College of Emergency Physicians, the Annals of Emergency Medicine in 2019. It's called Concussion Care in the Emergency Department, a Prospective Observational Brief Report. And it really details a lot of this data I just talked to you about brain injuries in the ER. And finally, and most importantly, for most of our cases involve mild traumatic brain injury, a common misconception, a common defense is if your client has a mild traumatic brain injury, then their symptoms will resolve in 3 months, definitely within 12 months. It used to be called the miserable minority. Used to say it was less than half of individuals with mild traumatic brain injuries still have problems after a year, and they try to claim your client is malingering or exaggerating. Well, that's been debunked with more and more studies and more tests being done and data and research into mild traumatic brain injury. A great peer-reviewed journal article came out that's called Recovery After Mild Traumatic Brain Injury in Patients Presenting to U.S. Level 1 Trauma Centers. It's by JAMA Neurology in 2019. This found that after following a large number, high hundreds, maybe even over 1,000 individuals with mild traumatic brain injury over a long period of time, that after 12 months, after 1 year, more than half of the individuals with mild traumatic brain injuries still had symptoms and deficits, more than half. So it's no longer the miserable minority, it's now the miserable majority. And that's a very, very important article to have and to make sure that your clients, treating physicians, neurologists, physiatrists, even neuropsychologists are aware of, because most of our clients still have deficits more than 12 months. So those are the 4 common defenses we always see. Hopefully, this gives you some insight on how to deal with them and some resources that you can look into and use in your cases. With that, I appreciate your time. Again, I'm Jay Vaughn with the law firm Hendy Johnson Vaughn Emery. Thank you.